to avoid a general anesthetic, so she insisted she wanted to wait until after the pregnancy before she had any treatment. So, and she's 3 years post-treatment and she's doing fine. That corner was being ignored. I'm only taking questions from that corner now. We'll take 2 from there and then we'll take from you.
Good afternoon, sir. Good morning, sir. So my question is it a prerequisite to have a minimum Konosky score, a minimum score on the performance index in order to proceed for surgery for any kind of a tumor?
Ooh. That's a very good question again. The answer is no, because every patient is different. And again, it's really down to what you're trying to achieve. So what you would want to do is optimize the patient as best as you can. And I think the answer to your question is that it would really depend on the comorbidities that the patient has and its likely impact on that patient's overall prognosis. So if I had a patient with severe COPD, who was on home oxygen, for example, and they had a head and neck cancer, which I could treat surgically, I would have a conversation with my anesthetist. So that might be someone with a performance status of 3, potentially, or a Konosky of, 50. In an oncology setting, if there was a case of a clinical trial, they would not be eligible for a clinical trial, full stop. But I would have a conversation with my anesthetist, and the question I'll be asking is, can I operate on this patient safely and deliver them back to their relatives, with the minimum morbidity? And sometimes you just have to have a conversation with the patient and say, well, there might be a risk that you might not. I never tell them that they won't wake up, because I can always deliver them out of the surgical theater, but they might go into an ITU setting and never wake up in ITU. So you do have to have that conversation on a patient-to-patient basis.
Thank you so much, sir.
Okay.
A couple of the papers in your presentation had mentioned a hazard ratio.
Yes.
What exactly is that?
I was worried you were going to ask me that. So the way to think about it is just the additional probability of an adverse outcome. Okay. So if a hazard ratio of 1 means that there's equivalence. Okay. If you're more than 1, then it means that you're more likely to have a bad outcome depending on what you're comparing. Okay. Now, it's really important when you look at hazard ratios or odds ratios or whatever it is, that you look at the confidence intervals. That's really important. Okay. And I can tell you a story. We haven't got time, but you can really impress everyone when you put confidence intervals in your talk. Because I remember being at a presentation, national presentation in the UK, and the 2 or 3 speakers ahead of me had put all their data, but they didn't put the confidence intervals. And one of the big grandees stood up and said, you guys, you're rubbish. You should put your confidence intervals when you present your data. And I was next. So everyone was kind of looking at me because the slides had already been prepared. I couldn't, add. But thankfully, I'd actually remembered to put the confidence intervals in. So I was the only one in that whole meeting that had confidence intervals. So it made me look very good. So always remember your confidence interval, because if you've got a hazard ratio of 1.5, but the confidence interval is from 0.6 to 2, then that shows that really it's not significant, because it may actually be associated with a better outcome as opposed to an adverse outcome. Does that answer the question?
Yes, it does.
Okay,
thank you.
good. Phew.
Good morning, sir.
Okay. Yes, all right.
So I wanted to ask, we have discussed about the comorbidities which were already present in the patient. So what about the surgical comorbidity that we are adding if we don't have a negative margin in the tumor that we have resected out? So is there a way that we can, before the operation, we can decide that if to reduce this surgical comorbidity? Yeah. How can we decide before the operation?
Yeah. Well, as you know, surgeons, we never cause any complications, as you know.
Also, the comorbidity of the surgical trauma.
Yeah, surgical trauma, what's that? Okay, joking aside, you do have to consider the fact that surgery is not without its own side effects. The side effects tend to be short-lived, So things like wound infections, bleeding, nerve injury, things like that. So in the context, when I'm looking at a patient, when I'm sat in a multidisciplinary meeting, the first question I'm always asking myself is this something that I can treat surgically? Can I cut this out with a clear margin and maybe give adjuvant radiotherapy if necessary for the best chance of cure? But if the scans are telling you that this is more advanced or quite extensive, and in the process of removing the tumor, I will have to take the accessory nerve or the carotid artery or other important neurovascular structures, then I will not proceed in the first instance. Does that answer your question?
Yes, sir.
So you do need that multidisciplinary approach. Usually you have your oncology colleagues telling you, you're never going to get that out. That's usually one way of stopping you from,
Okay.
I think we've got 1 minute.
One more question and then it's coffee time.
Hello. I had a question, like if a patient has some solid tumor for which the radical treatment is a surgery. However, the patient has a lot of comorbidities like, say, for example, uncontrolled hypertension and diabetes, due to which he would not be getting fitness for surgery. So essentially, you are delaying the radical treatment till medical stabilization occurs. So during that period, do you give some other form of treatment for that particular cancer, like for example, radio or chemo? And if that is given, would that be considered as a neoadjuvant therapy if that patient is taken later for surgery?
Yes, so you could argue that there are some situations when you might want to buy yourself time, but you have to ask yourself the question, if the patient's already unfit for surgery, if they have significant comorbidities already, the likelihood of them being fit for, we're talking about chemotherapy here, the likelihood for them being fit for chemotherapy will be quite slim as well. So in the context of radiotherapy, we're not usually a fan of radiotherapy as a neoadjuvant treatment. I don't know in other tumor types if that's but in head and neck, it's either primary treatment or you have radiotherapy as your primary treatment, and then you have reserved surgery for salvage. So we don't usually, but chemotherapy might be an option, neoadjuvant chemotherapy. But as I said, if they're already unfit for surgery, then the likelihood is that they'll be unfit. Would you agree that in that context that they'll probably be unfit for neoadjuvant chemotherapy?
Thank you.
Excellent. So we've got the coffee break now. So everyone's going to be waiting for coffee. You can grab these guys. They're here all week. Okay. But we're going to be back here at 11:30. Okay. And this is going to be our first multidisciplinary team meeting. So a lot of the very tumor-specific questions you've been asking are perfect for these sort of scenarios. Okay.